This is a general disclaimer. Redlands Community College attempts to have the most accurate and up-to-date information listed in its content and delivery. However, your education is your responsibility. Redlands Community College or Roy Smith makes no guarantee in the accuracy of this information in this video and accepts no liability for the informational video. The information expressed is strictly the opinion of the author and the presenter, which is listed in the reference near the end of the video. This information is designed to supplement your own education or initial education and should not be used to replace any current academic program you're enrolled in. View the information and content at your own risk. Thank you.
This is going to be Chapter 28, Blood Products and Transfusion. After completing this chapter, you'll be able to understand the components and production of blood groups, compatibility and cross-matching, identification and treatment of transfusion reactions, specific transfusion procedures before, during, and after transfer. Quick brief history of transfusion. The first recorded transfusion took place in 1665 by Richard Lohr and started transfusing between dogs is how it started off. 1667, French physician John Baptiste Denis transfused approximately 9 ounces or 260 ml of blood from a sheep to a young male patient. Patient survived but had urine as black as soot. Late in the same year, animal-to-human transfusion was outlawed in France and several other countries after several deaths. The first human-to-human transfer was performed in 1795 by Dr. Philip Physick. A little more than 20 years later, obstetrician James Blundell performed the first known blood transfusion to treat severe postpartum hemorrhage. In 1901, physician Karl Landsteiner discovered the existence of different proteins on the red blood cells, and this was first described, or the first description of blood groups. Safety in this continued to improve. Methods to prevent clotting were discovered. Research discovered that blood could be stored at cooler temperatures, allowing its use for longer periods of time. The first blood bank was created in anticipation of heavy casualties in World War I. U.S. Army physician Oswald Robertson collected and stored blood before the Battle of Cambrai in World War I. Within 20 years, civilian blood banks began to develop in the United States and Europe. In the 1940s and 1950s, scientists developed methods of separating whole blood into the components. During the 1960s and 1970s, advancements were made in the development of identification of components that could be used to prevent antibody formation, treat hemophilia, and direct infections and detect infections transmitted by blood product in the transfusion. And this is going to be table 28.1 that we'll look at here in just a second. And these are infectious diseases that are tested for in donated blood: HIV 1 and 2, HTLV 1 and 2, hepatitis B, hepatitis C, West Nile, Tryponium palladium, causative agent for syphilis as well. Blood components. Main solid components of the blood are the ones listed here on this slide: red blood cells, white blood cells, and platelets. Blood also has many other proteins. Many blood components are measured as a part of a complete blood count, and we'll look at the CBC stuff here in just a second. Figure 28.1, hematopoiesis, my apologies, is the production of major blood cell types. And brief overview of this: all of these come from the same cell. So that's the cell that starts it off, or hemopoietic stem cell. And from that you get your red blood cells. These are types of white blood cells, which we'll talk about. Eosinophils, neutrophils, and basophils. These are also types of white blood cells, a little bit more specific. Monocytes, and then your T cells or your lymphocytes. And then the platelets also are formed in peripheral blood, the thrombocytes. And these are formed by a metamegakaryocyte. Little particles, not really a whole cell. Figure 28.2, the erythrocyte or red blood cell. The red blood cells, also known as erythrocytes, are a small donut-shaped cell that act to transport oxygen from the lungs to the cells. Now, these have hemoglobin on them and carry oxygen and CO2 transport. And this is figure 28.8. White blood cells, or leukocytes, function as a part of the immune system. There are three subtypes of leukocytes. There are basophils, neutrophils, and eosinophils. And they react against and attach themselves to certain type of infectious organisms. After attaching to the organism, they release toxic chemicals in an attempt to neutralize the invading organisms. Macrophages are larger cells that attack and destroy foreign invaders after the leukocytes identify the foreign material. Lymphocytes identify foreign materials and develop antibodies against them to allow and enhance the immune system response. Platelets are responsible for blood clotting, and platelets are attracted to a damaged red blood cell in the endothelium. Coagulation factors and other proteins attract other circulating platelets to the damaged area as well, and they build a plug, or like a patch. Coagulation factors are proteins that attract platelets to each other to build a platelet plug, and they are key in the production of fibrin and fibrinogen. Now, over here on your right, figure 28.5, if we'll all take a look at this here really quick. Vitamin K dependent and these are the factors, which are 9, 7, 10, and 2. They're all dependent on vitamin K and the ability to get to or form the common pathway. Cofactors to assist this would be 8, 5, that would assist this movement or this cascading of factors together to where we form the common pathway, and then that gets us fibrinogen and fibrin, which is the polymer that sets up the actual clot production. Components, normal ranges. Blood also has many other proteins that circulate through the system, serving multiple functions. Many of the blood components discussed are measured as a part of a CBC, or complete blood count, and these are the things that are in the complete blood count. Let's go back one slide. Red blood cells are 4.5 to 5.5. White blood cells, 4,000 to 10,000. Hemoglobin, 13 to 16 in a male and 12 to 15 in female. Hemocrit, and this is the percentage of red blood cells, 41 to 50%. And then in the female, 36 to 44%. And then platelets, 100 to 450,000 platelets per milliliter. Low platelets below, say, 100,000, say if you only had 20,000, be an example of this, you would not have very many platelets to stop an active bleed. Blood products. Transfusion of whole blood has become uncommon. So an example of this, we are going to the formed elements of the blood instead of giving patients whole blood. Blood products include packed red blood cells, which is essentially a 250 milliliter by volume concentrated version of red blood cells. The fresh frozen plasma, formed by removing the red blood cells and platelets from the whole blood. The remaining liquid is rich in clotting factors, so if someone's having some bleeding problems, that's what we use FFP or fresh frozen plasma for. Cryoprecipitate, protein portion of the plasma made up of concentrated clotting factors and is much smaller in volume than the fresh frozen plasma. Contains factors 5, 8, and 13, fibrinogen, fibronectin, and is essentially used in patients that have, let's say, DIC or disseminated intravascular coagulation, von Willebrand's, hemophilia, things like that. So both the fresh frozen plasma and the cryoprecipitate are used for people with bleeding problems. And then platelets, and these are separated from plasma in the blood bank. Each unit of platelets should be transfused over about 30 to 60 minutes. And then in general, to raise a patient's platelet count by 50,000, the patient needs to receive approximately 6 units of platelets if we order them individually. And platelets would be the emergency patches, so to speak. Blood groups and compatibility. There are 3 blood group typings. Important concepts for blood group typings: proteins that exist on the surface of the cells help the body identify which cells are its own or which cells are foreign invaders. So if we get a match that is incorrect, the body isn't going to recognize it as self. So it'll form an immune response to this, or an antigen-antibody reaction. We are concerned with agglutination occurring, or clumping of the actual vessels. If agglutination occurs when the blood cells clump together, they kind of break down. This causes hemolysis. Compatibility. We should talk about universal donor and universal recipients. I'm going to talk about it a little bit on the next slide because I got a nice picture. Blood A recipients may only accept essentially 2 types of blood, and we'll explain this on the next one. So A will accept itself and O. B will accept itself and O. AB, the blood type AB, so we can actually have 4 blood types. We can have type A, type B, AB, and O. Let's wait till the next slide to where we have the picture so we can talk about this. Transfusion terms, typed and cross-matched. We are going to talk about this here so we kind of understand. So a blood type, if we get a blood type on somebody, the only thing that we actually know at that point is what blood type they are. A crossed, the donor that has successfully matched to the recipient blood is called type and crossed, or they understand the type and they've cross-matched it with the blood. In some cases, if there's insufficient time to complete an absolute cross-match of the recipient and the donor blood, they may use things like universal blood typing, which would be like O negative and O positive. The ultimate version of this would be the O negative, because the Rh factor is a consideration as well. This is figure 28.6, and this is agglutination. And what agglutination does is it clumps together. So after there's been an antibody antigen reaction, the blood cells kind of clump together, and they will kind of self-destruct or cause hemolysis to occur. Over here on figure 28.7, these are the major red blood cell types, and there are essentially 4 types whenever we're looking at this. So let's just kind of run down this and talk about this here for a second so it makes a little sense. Alright, so we're going to talk about this guy first, which is type A. Type A has A antigen on it, which means that I am presenting a protein on the surface of my cell that identifies me as type A blood. Now, also circulating in there, it has the antibody for type B. So very simply, I'm going to go over to the next slide here. This over here is type B blood. If this red blood cell came into contact with this antibody, it would cause an antigen-antibody reaction. Alright, go into type B blood here really quick. I have the presenting antigen of B, so I can identify myself. This one was A. And I have the antibody for A. So if I get type A blood, there's going to be an antigen-antibody reaction, and vice versa. If the type A person gets type B blood, an immune response or an antigen-antibody reaction. The AB blood type has no antibodies, so the universal recipient of anybody's blood would be AB negative. And the reason I brought the negative into it, it would actually be, the blood type would be just AB. But the negative is an Rh factor. It's another protein factor that we can identify on the red blood cell. So, and it is identified by either negative or positive. So if you are Rh positive, or have A positive blood, you are blood type A with an Rh positive factor. And what this is another protein identifier that's on there. So that positive factor is another thing that can create an antigen-antibody reaction. So AB and AB negative, which would not have that extra protein identifier, would be the universal recipient. The universal donor is this guy right here, O. Now O has both A and B antibodies in it. However, it has no presenting factor to identify itself. I have nothing to identify me. So most of the time, O negative, which would also have no Rh factor to it, would easily slip into the system. So the universal donor is going to be O negative. There are 29 different types of blood grouping systems recognized by the ISBT. We pretty much utilize the ABO version of this in the United States. And let's see if I can get this working. So the ABO system is what we utilize. If the recipient type has, now this over here is this is 28.5 in your book. And this is the type of blood that your patient actually has. So if they have type A blood, they can receive type A and type O. If they have type B blood, they can receive type B and type O. Remember, O doesn't identify who it is. If they have O blood, they can receive type O blood only. If they have AB blood, then they can take type A, because remember, the AB blood, if we'll go back to this, the AB blood has the identifier for both A and B, but has no antibodies. So whenever we're looking at that, type AB blood can take type A, type B, AB, and O. The universal recipient. Rh positive and Rh negative blood. If you are Rh positive, then you can take Rh positive, or you can take Rh negative. If you are Rh negative, then you can only receive Rh negative blood. Identification and management of transfusion reactions. Now, we look at each one of these. So a transfusion-associated circulatory overload is very simply, we gave them too much blood. More likely to occur in patients with actually impaired cardiac function, essentially produces pulmonary edema in these patients. An allergic reaction, the one that we kind of watch for the most, is the degranulation of a mast cell. So we've had some kind of antigen-antibody reaction in there, or there's been an allergic response. Most of these will resolve spontaneously. Some will require medication. Febrile non-hemolytic reactions. So this will increase their fever, or give them a fever, or increase their temperature by 1 degree Celsius from baseline within 2 hours. They may get chills, rigors, headache, nausea, and vomiting. Fever may resolve spontaneously, often after antipyretic medication like Tylenol has been administered. An acute hemolytic reaction is probably the most serious, and this often results from an incompatibility from the ABO blood typing. So the blood cells clump together and they essentially bust apart and hemolyze. Bacterial contamination occurs at a rate of 1 every 15,000 units of platelets and 1 in every 500,000 units of packed red blood cells. Most commonly, it's caused from contamination which occurred during the collection or storage process, rather than from an illness on the donor. Transfusion-related acute lung injuries. Now, TRALI, T-R-A-L-I, essentially has a rapid onset or development of hypoxemia, dyspnea, bilateral infiltrates that can be seen on chest X-ray. occurs as a result of the pulmonary capillary leakage of the plasma into the tissues surrounding the alveoli in the lung. It is believed that TRALI is set off by the antibodies against white blood cells that are present in the donor's blood and react with the recipient's white blood cells and cause kind of an immune response. Treatment of transfusion reactions. We generally treat them by stopping the transfusion, changing the tubing, and flushing the line with normal saline. The unit of blood products in the line must be saved and given to the blood bank and told that the patient has been in a transfusion reaction. Contact online medical control and discuss specific patient development plan. Administer high-flow oxygen. Essentially treat for an allergic reaction. Things like diphenhydramine, methylprednisolone, or solumedrol. If they have airway edema of any sort, consider the use of epinephrine intramuscularly to treat the anaphylaxis. Watch for containment loss because vasodilation occurs in anaphylaxis, the causes of anaphylactic shock. So the epinephrine may be switched to a lot quicker depending on your patient's condition. Patients that develop TRALI will often require CPAP or intubation to maintain their airway status and oxygenation. Signs and symptoms of an acute hemolytic transfusion reaction. This is table 28.6. Fever greater than 2 degrees Celsius above the patient's baseline. Hypotension, difficulty breathing or dyspnea, pain at the site of a transfusion, back and chest, hemorrhage and or hemoglobinuria, dark-colored urine, or it looks like the urine is brownish, nausea and vomiting, jaundice, and icterus. Now, icterus is the technical term for jaundice. TRALI, this is table 28.7, signs and symptoms of TRALI, is transfusion-related acute lung injuries. Difficulty breathing or dyspnea, tachypnea, cyanosis, fever, tachycardia, and froth from the endotracheal tube. And this would be from non-cardiac pulmonary edema. Transfusion procedure and documentation. Prior to the transfer, the paramedic needs to confirm several items before receiving the patient and blood products, and this is on table 28.8. We'll talk about it in just a second. It's the next slide. During the transfer, blood is transfused through one of two types of administration sets. A blood transfusion set is preferred over piggyback. Blood products must be stored in an appropriate transport cooler as well that is certified by the blood bank. You can't just use any old cooler. The paramedic should record the vital signs throughout the entire transport of this while the patient is taking blood. After the transfer, paramedic must document at a minimum the vital sign, the times, the reactions, and information about the blood products administered to that patient during the transfer. The paramedic should use a specific form required by the actual agency. So if you're transporting blood, there should actually be a blood transport form. One copy of the transfusion record should be left at the receiving hospital and another copy left with the pre-hospital care provider. Any unused blood products should be given to the blood bank at the receiving hospital. And this is items to confirm prior to transport. Verify the patient's identity, which is essential. Verify consent for the actual transfusion or indication for the reason for implied consent was used. Verify the patient's blood type, A, B, O, and Rh factors. Verify transfusion orders, the type of blood products, the rate of administration, and the order of administration if you have multiple products. For each unit hanging or carrying during transport, verify with another paramedic, RN, physician, or mid-level provider. Blood type per unit, Rh factor of the unit, patient's ID label, unit expiration date, and donor unit number and patient identification match, or information match. And this is table 28.8 in your book. This is a transport cooler certified by the blood bank. Now remember, they have to be certified and be sure that they're adequate. These are under probably CLIA specifications. In conclusion, transfusion of blood products during critical care transport can provide a life-saving therapy to the critically ill patient who require blood products. And it's important to approach blood transfusions methodically and systematically. And it's critical to continuously monitor the patient during the transfer. Very easily could they go into a reaction that, if you weren't paying close attention, could cause an untoward effect towards your patient. References for this chapter can be taken or can be found in Richard Beebe, Professional Paramedic, Volume 1, Foundation of Paramedic Care, First Edition, pages 598 through 611 of Del Mar Learning. If you have any questions concerning this chapter, feel free to give me a call. My name is Roy Smith, smith@rmsa.net, 45219-7613. Thank you.